I laugh at that one just because I've had physicians ask me that. They call us the police people of medicines, and it's not true. The first thing we do before we ever look at costs, and I'm speaking even from a we call it P&T committee, but pharmacy and therapeutics committee, right? We always look at the clinical utility of the drug first, always. When in the hospital setting, the doctor will write an order in and you receive it on your end and you're just kind of like, nope, that's not on the formulary. And you'll get this phone call, who are you? I wrote this prescription. You need to release this. And there might be some expletives in there as well. A lot of times we're the messenger. So we're like, well, the P&T committee met and then still, well, I think this should be on there. And they're making the case to you. And that is challenging. And I think that's where kind of this idea of us being the policemen of meds comes from, because we're kind of in a position where we have to enforce the formulary because, we have all the meds there. And I think what's important here is for us to all just kind of realize that it's not about the egos and it's not about turf wars. It's about the patient who is in the hospital bed who is waiting for that medicine.
So there's a misconception that prescriptions can be written and unwritten without any consequences. When a physician writes a prescription, a pharmacist is obligated to prepare that medication. And if they did not pay attention to what dose were they writing or how many of those tablets they were writing for, can't just be taken back. So I've had a situation where the physician told the patient, I'm going to prescribe you this antibiotic, let's say a antibiotic. And they come to the pharmacy expecting to pick up, prescription A. And we actually received an order for a completely different antibiotic. And they're a bit taken back. Oh, the physician told me they're prescribing me something completely different. This doesn't sound right. I don't want to take this medication. If physicians have questions about a medication order they're placing, they should certainly contact the pharmacist to help in assisting and inputting that order. Because once they sign that order, there's a potential for that patient, to get that medication.
There's always a misconception that pharmacists only count pills, but there's a lot that goes behind the scenes when a pharmacist dispenses medications. So first of all, the prescription has to be written correctly. It has to be the right dose. It needs to be the right drug. It needs to be the right route. And a lot of times, it's not just pouring from a large bottle into a small bottle. On the outpatient environment, it takes a little bit longer. So let's say a patient comes in, let's say for a pediatric patient, but the dose seems a little higher than normal for a pediatric antibiotic. Essentially, you don't tell the patient that, we expect this drug is wrong doses. You just essentially say, there's some clarifications we have to ask the physician to make sure that we're giving the right medication and the right dose. That takes a lot of time for you to call the outpatient provider, expect them to call back, and then before to dispense the dose. So it's usually difficult on the patient's end, but most of them do understand it is important that you have to check the doses of the drugs. Additionally, if it's something that it's unique and it's a little bit off-label or non-standard, just maybe you could give the pharmacist a heads up so then they are aware, and then just knowing that this is intentional versus just an unintentional, tenfold dose increase or something like that.
So there's a misconception that pharmacists cannot write prescriptions, and that's false. It's couldn't be further from the truth. I think that comes from the fact that about 15, 20 years ago, we could not. When I say we could not in many states. And there was a push in the pharmacy profession to shift that. So I think a good example is a patient who I'll call Miss Garcia, all right? And Miss Garcia will come in, she'll see us, and she'll need refills on several of her medicines. We'll call up the pharmacy doesn't have any refills on record. And she needs the medicines. I'll call up the doc and say, hey, I'm seeing your patient. This was the assessment. She needs X, Y, and Z. And the acute interaction is there's usually a sigh, because when we call the physician's office, the physician is already seeing 30 other patients that day, right? So there's okay, do I need to call in? I was like, no, I can do it for you. And then usually the response is, really? You can call in a prescription? And I say, yeah, actually we can. And they're like, wow, yes, do that. Call in the prescription. In fact, call in the refills. Do you need my DA number? No, I have my own DA number. Oh, wow, that's great. Good to know.
Pharmacists can definitely specialize, and there's actually a wide variety of specialties in multiple practice settings. So in general, there is outpatient pharmacy and inpatient pharmacy. Oftentimes when we get new practitioners or we get a new attending on the medicine service, I come in the morning and I introduce myself. Hi, I'm Sammy. I'm the pharmacist. And they're like, oh, wow, you round with us. Okay. So they're always a little taken back that we're actually participating. They may not have known when I introduced myself what my role was, but by the end of rounds, they understand that I'm a clinical pharmacist. I round with our internal medicine teams, and I'm a specialist within that area. And I help them with an array of questions, from drug information to drug dosing to ensuring that an appropriate therapy is selected for each patient.